Hi, it's Tom here from Running Physio. Today is episode 3 of our Getting Unstuck series. So these are, really designed to help you in clinic with common challenges that you face. And I'd like to thank John for sending through the case study that we're going to talk through today, because hopefully this can illustrate really what we're trying to say with this. Now, today's episode is about what to do with a patient when their pain simply won't settle. You feel a bit stuck, they feel a bit stuck, and it's difficult then to make progress. Now, I will say from the outset, I don't have all the answers for this. I don't want to pretend that there's a simple list of things you do, step 1, step 2, step 3, job done. That's not the truth of it, and we know that in clinic. So what I want this to be about is ideas, not pretending we have all the answers. I think it's important we acknowledge that everyone encounters these challenges at times where you can do absolutely everything right, and yet the pain just seems to linger. And then we have to make decisions with the patients about the next step. So here, hopefully we can look at next steps that you can take, considerations that you can use, things that you can do that perhaps can help settle the pain or explore why the pain isn't getting better. And then sometimes progress that you can make, even if the pain isn't settling, there are ways that we can still make progress with patients. Now, a lot of the patients I see at the minute might fall into this category. Sometimes they've seen other physios, things haven't improved. They may have been in this situation for really some time. So it's something I see quite a lot. And in many cases, we can make progress if we put the right strategies in place. And one area where we've had lots of comments and questions where people do feel stuck is iliotibial band syndrome. It is a tricky one to treat, and there's not a great deal of evidence for it. So we put a great webinar together for you all about that, how to assess it, how to treat it. There's bits in there about rehab, gait analysis, etc. And I've put a link in the title, so do check that out. Look at our free webinar series on iliotibial band syndrome. So let's talk a little bit about this case study we're going to talk about today in this video, which is a 35-year-old male runner with a roughly 10-month history of patellar tendinopathy. It seemed to come on after quite a large amount of training load. He was running 3 ultramarathons and 2 half marathons, so quite a lot going on in terms of loading, and that's often the way with tendons. They seem to react to excessive load. Now, he's got ongoing, quite severe pain despite treatment, and despite quite appropriate treatment in terms of load management, in terms of exercise selection. Heavy isometrics have been tried, eccentrics, etc., but the pain still seems to be hanging on in there. And the patellar tendon is really quite sensitive on palpation, perhaps hypersensitive to that. There's been an MRI too, which is a really good idea sometimes in these situations when things aren't settling, to explore if there can be any other sort of differential diagnosis, particularly if you have other signs and symptoms like locking or giving way. But essentially that's confirmed the patellar tendinopathy, and nothing else has really come up there, so it's kind of ruled out those other options. And then the key factor to consider now, at this point, he hasn't run for 6 months because the pain has been severe enough to stop him from doing it. Simply reducing his training load wasn't enough for things to settle, so he stopped running, and yet the pain is still an issue. So we've got some way to go with this person in terms of hopefully reducing the pain and then trying to get them back to what they want to do, which is potentially ultra marathons. So we want to really work towards that goal potentially. So the first step in this then, if you have someone with pain that just doesn't settle, for me the first step is to consider, is there something that's still driving these symptoms? Because in many cases, if you take away the aggravating factors, or at least modify or reduce them, the pain will settle given some time. So why is that not the case? Is there something that's driving this ongoing pain that we haven't spotted yet? Can we identify that, and then can we work with that to try and help the patient's pain settle? So the first thought when it's tendinopathy is that, is there ongoing aggravating activity that we don't know about? Is the patient doing something on a day-to-day basis that's irritating it? And sometimes these will be things that actually they've been advised to do from previous people. So perhaps they're stretching it aggressively every day because they've been told to do that previously. Or they're foam rolling or doing some deep massage around the area because they've been encouraged to do that. Perhaps they're doing some exercises that you're not aware of that are stirring it up. Or perhaps it's to do with work. Do you know what their work involves? Is this person kneeling all day, laying floors, and therefore putting pressure on a very sensitive tendon and keeping that irritable? So I think it's really important as a first step to try and explore what's going on, not just in your sport, but in life in general. Is there anything that you think is still aggravating your pain and keeping this area very sensitive? So that's an important first step. The next thing is to look at the person's pain beliefs and behavior. And this is really important because when pain persists, and this is pain that has been going on for quite some time now, it's natural for people to worry about that pain, to focus on that pain, and actually sometimes to start to catastrophize about that pain. Now, quite often this is missed because people don't volunteer this to us. They don't tell us what they're worried about or that this is on their mind a lot of the time. So I think we need to explore that and ask this runner, so what do you think is going on in this tendon? Why do you think it's painful? Is it on your mind a lot of the time? And if it is, what are you thinking about? And there you'll often find people getting tangled up in, what does this pain mean? Is it a sign of damage? What does it mean for my future? And there's lots of other things wrapped around that. So I think it's really important to explore that. Now, occasionally with people, once we've identified that they're thinking about their pain a lot of the time and they're ruminating about it, addressing that and reassuring them that this isn't about damage and that it can get better, and encouraging them just to gently pull themselves away from repeatedly thinking about that and towards perhaps thinking about something else like a functional goal can help. Because if you get really sort of sucked into that cycle of thinking about and worrying about pain and focusing on pain, that can really prolong that sensitivity. It's also worth asking, is this pain still load related? Now that also helps you to identify the mechanism that's prolonging it. So by that I mean most tendon pain is fairly load related in that it tends to increase when we increase load. So you might see it when in a volleyball player, for example, patellar tendinopathy, very common. They've increased their training load, they're playing more competitive games, the pain increases. They reduce the load, typically you'd expect it to settle. But if this pain isn't really behaving like that with load, perhaps it's just there all the time, we might want to ask yourself, well, is it really a load related pain? And if it's not load related, does it make sense restricting their load? And sometimes the answer is it doesn't necessarily. If it's not fluctuating based on what they're doing, we might want to explore why it's fluctuating and actually say, well, let's start bringing some load back in. If it's not causing your pain to change, let's bring that back in. Let's start to bring these valued activities back in there if they're not actually changing your pain a great deal. And within that, then, when we're trying to identify this pain mechanism, we can look for signs of hypersensitivity and exaggerated pain response. Because if we're seeing that there's hypersensitivity perhaps to palpation or to simple day-to-day tasks, and the pain response is really exaggerated, that adds more weight to this idea that we're looking at a persistent pain state that is less linked to what's going on with the tissues and perhaps more linked to the person's attitudes and beliefs around pain and how the central nervous system has changed. And if we're finding this out, then we want to really focus on working on that, really delve into those beliefs, help someone to understand their pain, start to get them back to gradually to valued activities, start to de-threaten that pain, and then we'll start to see things improve. We may want to think about differential diagnoses or comorbidities that could be influencing symptoms. Could there be an issue with the fat pad perhaps, or patellofemoral pain syndrome? Are there other things going on? We have an MRI here, an examination which suggests that that's unlikely. But I do think it's important sometimes to think about other factors that can be driving symptoms. We see that sometimes in Achilles tendinopathy that isn't settling. We discover actually there's some involvement of the plantaris tendon that is compressing and irritating the Achilles. And actually, if that's not identified and addressed, it can lead to worse outcomes, particularly if we load it into a stretched position. So it's having a bit of a broad think about what else might drive it. And the final thought is thinking about systemic conditions, particularly if you've got someone with persistent joint pain or persistent tendon pain, because it can be driven by systemic conditions such as things like psoriatic arthritis. So I would routinely ask people with tendon pain, have you had a history of joint pain or swelling? Have you had any problems with your skin, such as psoriasis? Any changes in your nails, which you can get with psoriasis? Do you have early morning stiffness? Do you have multi-site joint pain? Any problems with your vision, your digestion, all those things that are linked to these more systemic conditions? Because if this is a patient that actually has an undiagnosed psoriatic arthritis, for example, that may well be driving the ongoing symptoms. And in particular, perhaps with that, we'd be more likely to see Achilles, insertional Achilles issues, or plantar fasciopathy, a bit more common. But these things can coexist sometimes, and if they're not identified, they can continue to drive symptoms. So something to be aware of. Another one is fluoroquinolone antibiotics. They have profound effects on tendon health. They can lead to lasting changes and real difficulties in progressing people's activity. So again, these should be one of the things on your mind when you're considering drivers of pain. Now in our Running Repairs Online course, in the track pack, which is our resource pack for people, we have a tendon health questionnaire, which helps to screen for lots of these things. So we encourage people to use that from the course to identify these factors early on so that they can be addressed. So step one, then, we've tried to see, are there ongoing drivers for pain? Can we identify them? Can we address them to give this an opportunity to settle? And in many cases, if you can find those drivers and address them, things will improve. Step two might be thinking, well, what actual pain relieving strategies do we have for this person? And it's quite important to have some, because it places a person in control of their symptoms. They can kind of turn that pain volume down. Now, if they don't have those strategies, it increases the threat value of the pain. They're no longer in control of it, and that can be really quite frightening. Imagine that for yourself if you've got ongoing persistent pain and no real way to actually settle it down. So this might be around exercise selection. Now we know isometrics are very popular in tendinopathy, but they're not a cure-all. And actually, when you look at the different exercises, there's quite an individual response to different exercises in terms of pain relief. So I would explore easing factors the patient's identified with you. I might try strategies in clinic. So we test it with a loading test, like single leg decline squat for this person with patellar tendinopathy. We try an exercise, could be low level isometrics, perhaps, could be some eccentric only, could even be cardiovascular exercise perhaps, and we retest it to see if those symptoms have changed. Then if they've improved, that can guide our exercise selection to give people some simple exercise strategies they can use regularly to calm symptoms down. We want to look at the activity modification. Now, this particular runner has been doing some Olympic lifts, which can involve really rapid movements, which will load the patellar tendon. Now, he's reduced those, stopped those recently, but if those were going on, we'd want to cut those down if they were aggravating symptoms. So really important, do identify those things that are really aggravating symptoms and see if you can cut them back to a bit more of a manageable level. Try not to create avoidance, but it's just modifying to let things calm down. It might be if someone's very pain focused, that actually what we need to try and do is distract them from their pain, and often distracting them with valued activities that they enjoy, socializing, reading books, actually drawing them into something which gives them that feeling of flow where they're really focused on that enjoyable activity for a while and not so focused on their symptoms. And we've had examples of that with people who have sitting pain with proximal hamstring tendinopathy, that if they're trying to build up their sitting and they're just sat there with a timer focusing on their symptoms, it's not really going to work for them. But if they're sat there engaged in a really good book with a nice glass of wine on the go, enjoying an activity, absorbed in that activity, that can help be a way to reduce that pain focus and get them back into enjoying, valued things in life, really. And final point may be analgesia. Now, this is always a bit controversial in tendinopathy, and we have to recognize that there's not a great deal of evidence to suggest one form of analgesia is going to be better. But there is a thought that in truly very reactive tendons, that a short course of ibuprofen may help to reduce that reactive response. So we might be looking at a week, 2 weeks maximum of a short course to settle a very reactive, irritable tendon down. But this is often best used as it's directed on a packet. So typically, 3 times a day with food, as and when analgesia for this doesn't really tend to be quite so effective. So that might be an option we would consider, but only if we have those other strategies in place and it's not contraindicated for various reasons for the patient and they're on board with trying that. So we've looked for potential drivers, we've looked for trying to identify pain relieving strategies. The third and almost the final step in this is then to ask ourselves, has enough time been allowed for things to settle? We need to set our expectations realistically. Now, it can actually, even with the right things in place, it can sometimes take weeks for a very irritable tendon to settle. So we shouldn't panic if a couple of weeks go by and the symptoms haven't changed a great deal. It can take sometimes 6 to 8 weeks for it to settle. So I think sometimes we have to have the confidence to put the right things in place, try to reduce those drivers and put pain relieving strategies in place, try and help someone really understand their pain. That's very, very important, so we can reduce that catastrophizing and worry, and then give it that time to settle and not feel we've got to throw lots of new things in if things aren't improving. Now, it might be as well that part of the reason why it's not settling is because someone's not being particularly consistent with their load management. Now, we see this quite regularly with athletes where sport is a huge part of their life. There may even be a little bit of exercise addiction involved in this, that they really struggle without doing their sport. So they'll load manage for a short period of time, but they won't be able to maintain it. So we can then end up with a bit of a vicious circle like this. So we have a flare-up in pain, perhaps initial irritation from a big increase in training load. And then they manage the load to recover for a short period of time. They're prepared to give it a week or two. But then after a week or two, they're getting itchy feet. They're desperate to get back out there running. So they lose consistency in that load management. Then they start to reintroduce activities too quickly and they flare their symptoms up again. Now, this can then lead to a real kind of boom and bust pattern. And this can prolong pain because it's never really getting a chance to fully recover. So if you're encountering this with someone, I think you need to look at some of those drivers. Why are they continuing to flare things up here? Is there something driving that training behavior in terms of perhaps they're running or training for their mental well-being or other aspects? Can we address that to actually allow them to give it enough time to settle before they start to rush back into all the things that they want to do? So a few thoughts there. Look for drivers of pain, look for solutions to settle symptoms, allow enough time and make sure people are as consistent as they can be with the load management during that time. Now, if you've done these things, you've identified these drivers, you've looked at pain relieving strategies, you've given it sufficient time, and the patient does understand their symptoms and you feel that they've got a good understanding, a grasp of what's going on, but the pain still isn't settling, it's then reasonable, I think, to start to shift the focus from the pain onto function and start to say, well, look, let's not wait for this pain to resolve before you get back to what you love and get back into your life. Let's look at building up your function, your valued activities in a way that feels manageable for you. And really, it's for them to define what is manageable for them. Now, this might start by looking for what I call non-painful gains in your rehab. Now, John actually, who suggested this case study, mentioned some of these. So could we, for example, with this person with quite irritable patellar tendon pain, could we start some strength work around the hip with things like sideline leg lifts or, exercises where there's actual minimal load on the tendon, but we could start to build strength in other areas that might be weak, such as around the hip, perhaps around the trunk, around the calf, to try and look for getting non-painful gains in other areas in the kinetic chain. It's also likely those rehab activities will have some pain relieving effect. So can we look for those non-painful gains? Can we look for non-painful gains in function? Are there other activities this person can tolerate really quite well? You know, do they find cycling or swimming perhaps is really comfortable because it's not loading the tendon with impact as running would be? So can we start to look for non-painful gains initially to start showing them that they can be active and build that confidence up? Then it's quite a good idea to work on a rehab activity ladder with a patient. So ask them, what are the things that you want to get back into? What are your goals here? And let's make a little bit of a ladder with the easiest ones at the bottom, the ones you're going to find most manageable, and then the next more challenging idea, and then we build up through the ladder. So we start to layer things in. I have a patient, for example, at the minute, her main things she wants to do are hill walking, cycling, and running. Now, she knows she can tolerate the hill walking quite well, so we might build that as a first step on that ladder. Cycling's a bit provocative, so we might start to bring that in as symptoms settle, or perhaps bring it in a bit more gradually. Then, as we're a bit further up that rehab ladder, we might start to introduce impact and start to expose to running and build from there. And this is this idea of sort of layering things in. So we establish what's manageable sort of one step at a time and start to layer things in. And the analogy I use for patients with this is it's a little bit like an allergy diet. I don't know if any of you have ever experienced that, but sometimes if someone has quite allergic reactions to food, they strip foods right back to a very basic diet of sort of plain rice, and then they start adding food types in one at a time to see what's tolerated and start to build a broader diet for this person. And it's almost a similar idea. We strip things back to what we know is manageable, then we start to layer in new activities based on the patient's goals and establish what's manageable before then building on towards where they want to be. Now, an important part of this is that we're shifting the focus away from pain as much as possible. And this image here is something that I draw quite often on the whiteboard in the clinic for our patients. Something I would often say is, you know, we think that if our pain hasn't changed, then we're not getting better. But actually doing more without an increase in pain is a significant improvement. So as you can see on the graph here, sometimes with people, what we can do is build those goal activities, make it about building that important goal activity. And if the pain remains manageable, we're still winning. And often what happens is over time, gradually that pain does start to dissipate and get better. But at least it's less disabling for them because they're actually able to do more and get back into the activities that they love and value. So there's really something in this idea of actually focusing on function, reassuring people, showing them that they can get back into what they want to do. And for this particular person with his patellar tendinopathy, I would hope if we can find the drivers, if we can find some solutions to calm the symptoms down, if we can give it sufficient time, then we could start a rehab ladder with him. Perhaps if isometrics are best tolerated, starting with that initially and seeing how he gets on, then maybe moving into some more traditional patellar tendinopathy rehab, perhaps starting to bring in some two-leg squats, some light seated knee extension, some leg press work perhaps, but based on what's tolerable. And then we can start to gradually increase the load with that depending on his symptoms, and then start to layer in some impact work and then plan a graded return to running, with him defining what he considers to be manageable symptoms. We don't necessarily in this need to be very prescriptive and say the pain must behave exactly as we want it to, because we can see there might be an exaggerated pain response. So following that pain response to the letter is not necessarily that helpful. So what we might choose to do instead is say, you define what's tolerable for you, you define what's manageable, and then we'll progress based within that. And sometimes with this, we can use, a self-defined traffic light system for patients. So they decide what are the signs where the traffic light is green for go. Perhaps symptoms have been fairly manageable. They feel fresh. They're not particularly fatigued. That's a good point for them to progress and start to push on with their valued activities. When is that traffic light amber? Perhaps they're a little bit niggly. They're starting to get a little bit more of a pain response from activities, perhaps. Maybe that's a sign that they need to consolidate their progress and stay where they are for a couple of weeks, or step back a little bit, have a recovery week to let things settle. on when is it a red light situation. They're in a severe flare-up, their pain is really increased, and actually they do need a period of more more consistent activity modification if that's aggravating their symptoms, to let things settle before they can start to then push and go again. Okay, so hopefully some ideas for you there for when patients have pain that doesn't settle. I'd love to hear from you. Have you got some patients that you feel stuck on with this? This series is all about trying to help you, particularly with clinic-based stuff. So please let me know in the comments and replies, is there something you're stuck with, part of assessment or treatment, perhaps a particular patient presentation? We can always have a little chat via email if that's the case. And then in the next video in this series, we can look to talk about it and try and help you, because I'm sure there'll be other people that are out there that are having similar struggles in clinic. And as I mentioned, if you'd like to find out more about running injury, do check out our webinar series on iliotibial band syndrome. There's a link for that in the title. I really enjoyed putting that together, and I think you'll really enjoy watching it. Okay, thanks again everyone for listening. See you again soon. Bye for now.